All right, well, it's 12:01, and in honor of everyone who has made it on time, we're going to go ahead and get started. Welcome, everyone, to the Recovery Audit Contract Stakeholder Meeting for the quarter. I'm Stephanie Denning. I'm the Deputy Director of the Medicaid Operations Office, and we have today with us Megan Morehauser, who's our Communications Manager, and we have Dr. Jeff Chapman, who's going to give us a great presentation about malnutrition coding and RAC updates. We'll give you a little bit of that information at the end of his presentation, but this was actually something that you all requested in the survey at the end of our last meeting. So we're excited to be able to bring you these kinds of presentations and learning opportunities, and hope that you will submit questions through the Q&A. And we'll, without any further ado, I'm going to turn it right over to you, Dr. Jeff, because this is what everybody's really more interested in.
Was going to say, you made this sound really exciting, Stephanie. That's good. So, yeah. So, for those of you I haven't met, I'm Jeff Chapman. Since March, I've been the medical director for RAC Audits. Next slide, please. So, Healthcare Policy and Finance is the administrator of the Colorado Medicaid program, the CHIP program, and other healthcare programs for Coloradans who qualify. Next slide, please. Now, I always like to at least remind people of what our mission is. It's improving healthcare equity, access, and outcomes for the people we serve while saving Coloradans money on healthcare and driving value for Colorado. And part of the reason I put this up there is we need you, the providers, to be willing to participate in this program. And the reality of it is RAC audits are part of the program, but we want you to be engaged and informed. And our goal is to do these RAC audits, but also to take your interests into consideration. So we've been working hard to try and improve this process. Next slide, please. So why are we presenting malnutrition? As Stephanie said, someone in the comments said, well, why don't you give us a little bit of an update on how you're going to use guidelines when they're doing audits for malnutrition. But it's also a good topic because this was the subject of an OIG audit in 2020. And we're trying to stay ahead and say, hey, if the OIG is looking at things, we want to be sure we have fair and reasonable guidelines that we're using to do our audits. As you're all aware, there's increasing scrutiny of all Medicaid programs regarding fraud, waste, and abuse. So we want to stay ahead of the game and be sure that we are have good guidelines and the stakeholders have a understanding of how we're doing audits, what criteria we're using. And I realize not everybody's going to agree with the guidelines or the criteria we use, but we want to be sure that we hear your voice, and the only way to hear your voice is if you understand what we're using for guidelines. So next slide, please. So the malnutrition coding issues, and I mentioned the 2020 OIG audit, and they found that severe malnutrition was coded improperly in 86% of the cases. And the estimate was, and this was a Medicare audit, OIG investigation, that 1 billion was billed incorrectly. So this is something that's on the horizon, and again, we just want to be sure that we're on top of it, but also what we can do to help inform you of what guidelines we'll be using. Next slide, please. So the malnutrition codes are the E40 to 43 for severe malnutrition and E44 for moderate and mild. And one of the things we'll talk about is using what are called Glynn criteria and how you distinguish between severe and moderate. And then E45 is retarded development and E46 is unspecified protein energy issues. I will add a disclaimer that the discussion we're going to have today applies to adults. I'm going to have a discussion with our pediatric providers to get some recommendations on how we apply this to the pediatric population, because some of it is applicable, but it's a different animal for the pediatric population, and so I just want to be sure people understand that what we're talking about here is in the adult population. Next slide, please. So the OIG report talked about improper coding and the issues in the OIG audit and other things you'll read about is overcoding, severe malnutrition, and we're going to talk about these GLIM criteria and how you distinguish between moderate and severe. Lack of documentation, and part of that documentation includes when a patient is in the hospital that you've utilized resources that also justify the coding of a severe malnutrition, and misapplication of the criteria we're going to talk about, and actually even undercoding. There may be times where facilities are not getting the benefit that they would get from having a severe malnutrition code. Next slide, please. So, whether people like it or not, we've got to have some playing field to work from. Everybody's got to kind of be on the same page, and I understand not everybody is going to agree with what criteria we apply, but we've got to start somewhere. And so, my picture is to show we want to level the playing field by saying, hey, everybody needs to understand, like them or not, these are the guidelines that we're going to apply. We're always open to discussion. We had some good discussion regarding sepsis after our last stakeholder engagement meeting, excuse me. So in the past, the Aspen criteria were kind of the standard of care, and it's an older set of guidelines, and they're good guidelines. But in 2018, Aspen actually joined with multiple societies to publish the GLIM criteria. And GLIM is Global Leadership Initiative on Malnutrition. And I believe that for adults, these are the most widely accepted guidelines. And, the good part is they're fairly simple to understand, and they make some sense. And so that's what we're going to be talking about today. Next slide, please. So this is the reference to this publication, and there's certainly other things you can find out there, but this is kind of the original, and it's nicely done because it kind of explains the rationale for why they did things and goes into a little more detail than I'm going to go into as far as measurements and that sort of thing. Next slide, please. So the GLIM criteria have two different sections. One is phenotypic and one is etiologic criteria. And then the phenotypic criteria are what you use to distinguish between moderate and severe malnutrition. And I'll show you a little chart that talks about what the cutoffs are for each. But so in the basic GLIM criteria, you have to have one of the three. In weight loss, over 5% in less than 6 months, or 10% in greater of 6 months unintended. So obviously, if somebody's trying to lose weight, it doesn't really count. BMI less than 20 if you're less than 70, or less than 22 if you're over 70, and reduced muscle mass. And they talk about finding by objective measures, and we'll go over that. That one's a little more complicated, but I've got a slide that I can kind of show that to you. And again, there's a good article out on using or how to assess muscle mass when you're applying it to the GLIM criteria. Next slide, please. So, and then I told you there's a second, it's the etiologic criteria, and this relates to reduced nutritional intake, less than 50% of the requirement for over a week, or any reduction over 2 weeks that is significant, and then chronic GI disorders with adverse nutritional impact, and you're going to be your enteropathies and lots of GI related conditions, or an inflammatory condition related to a chronic disease or acute disease or injury with severe systemic inflammation, or social, economic, and environmental starvation. And the nutritional intake, the best way to do that is have your dietary people do a nutrition assessment. Just saying, oh, the patient isn't eating as much as they should probably is not the diet or the documentation that you're going to be asked to provide. And I think most hospitals now, facilities will do a nutritional assessment, at least a screen by nursing, and then if people meet the criteria, their issues, they'll get their dietary department involved. But again, the more you can document, the more likely you are to not have any issues. Next slide, please. So the malnutrition diagnosis criteria that our intent is to apply is first the physician or provider needs to document a diagnosis of malnutrition, presence of at least one GLIM phenotypic criteria, one etiologic criteria, and then documentation of significant resource impact in a treatment plan that corresponds with the severity of the malnutrition coded. And that's a big long sentence, but really what it means is just saying person has severe malnutrition, but there are no orders or nothing in the treatment plan or anything like that that says we're going to address this. The diagnosis has to be something that your intent is to treat and utilize some resources. So this is simple things like saying, we're going to have dietary see them and do a individualized treatment plan. We're going to do every meal calorie count if you're trying to support severe malnutrition. We're doing, supplements 4 or 5 times a day or enteral nutrition, et cetera, et cetera. You get the idea. So again, you always want to kind of write a story or create a story that supports a diagnosis like this. Next slide, please. So again, it's the differentiation between moderate and severe that probably caused a lot of the issues in the OIG audit. And so the differentiation between moderate and severe with GLIM is based on phenotypic criteria and the thresholds, and I'll show this in a slide here. And then again, like I say, documentation of resources utilized. And in all these guidelines that we talk about, there's always some clinical component that's going to come in. In other words, if you're reading a chart and maybe not everything is there, but there's something in the chart that says, clinically this is very obvious. It's I guess what I'm saying is there's some leeway when you can support something as far as for example, moderate versus severe. And so I would just encourage people to continue to work with their providers to do everything they can to support things when they're listening to diagnosis. Next slide, please. So these are the criteria, the phenotypic criteria that differentiate between moderate and severe. And I know you can all read this, but for example, at the top, a moderate is 5 to 10% weight loss in under 6 months, greater than 10% over 6 months, or excuse me, in less than 6 months, or greater than 20% in greater than 6 months, and so on. And so you can see it's degree, a BMI of 20 for moderate, less than 18 and a half for severe. And then the reduced muscle mass, mild to moderate deficit, and then there's this per validated assessment method, and we'll talk about that in a second, versus a severe deficit. And I think this one's probably the most subjective if you're going to use physical exam. There are some imaging studies that you can do that have criteria, but I think most people are going to end up using physical exam. So next slide, please. So just to touch again on documenting the resource utilization for severe malnutrition. If you've got mild or moderate malnutrition, you're going to give them some counseling, maybe a high calorie diet, 1 or 2 daily liquid supplements, versus severe where you've got more intensive resource utilization. They're closely supervised. They've got an individualized nutrition plan. You're giving them more than just 2 supplements a day. Or again, we talked about things such as G-tube or NG tube feeding, TPN, that sort of thing. And if the treatment plan is not going to be consistent with the diagnosis of severe malnutrition, it may be kicked out. And again, so my encouragement is just to be sure that you're really documenting well. Next slide, please. So I told you there's an article that talks about validating muscle mass that related to the GLIM criteria, and it's a good, basic article, and this is the reference to it if you're interested. Next slide, please. So basically, it comes down to two options. One is technical approaches, and BIA is biometric impedance analysis, I think is what they call it. And it's an instrument that you use, or a DEXA scan, or a CT scan, or ultrasound. And there are criteria and reference values. I think, again, is this something that's going to be as commonly used? I would guess not, but certainly that is one of the options in that article. Talks about the approaches to using the technical, and then there's the clinical approaches, which is I think where most people are going to land when they're trying to document for malnutrition. The anthropometric analysis is the skin test, skin pinch, the calf circumference, middle arm circumference. And again, I think a lot of dietitians and people in the dietary departments in hospitals know how to do this. But there's also the provider doing a physical exam, and the physical exam needs to be more than just saying patient has decreased muscle mass. Support with things like is so weak can't get out of a chair, is can only walk 10 feet, something objective besides just saying patient looks like they have loss of muscle mass. And so it's something that's certainly doable, and it's difficult because this may not be something that providers are honed in on documenting well, but I think it is relatively easy to do if you have the understanding. So, what my hope for the takeaways from this part of it is that you understand why we're needing to apply some guidelines. We want to level the playing field, be sure everybody knows where we're starting as a base point. With all these audits, we're always going to have the clinical piece of it, which becomes subjective. But again, if somebody says, well, it didn't meet every criteria you need, but here's why, we think, and that gets back to your documentation. And then also that this is not applicable to the pediatric population. And again, it's something I'm going to have a discussion with our pediatric providers on to come up. I've got some ideas, but be sure that they're on board with it. And I did not do that because partway through preparing for this, I realized that just like with the sepsis, we weren't considering the pediatric population early. So I haven't had a chance to do that before I gave that talk, but we'll come out with some more information on that. And as always, we want to engage you and be sure that we hear your thoughts on these things. And so certainly give us comments, give us feedback from the poll. And again, I apologize. I realize this is not something that applies to everybody on this call, but we thought of, well, what could we present that applied to everyone? And the answer is nothing. So we're going to try and do some other things, and especially based on feedback we get for some of the people that may not be strictly related to inpatient provision of care. So with that, next slide, please. Just talk a little bit about what's going on in the RAC program. So behind the scenes, there has been a huge amount of time and resources spent looking at the audit process to be sure that we create an efficient, fair, user-friendly process that fulfills the statutory requirements and does a good job of oversight of Health First Colorado. And the new process has lots of checks and balances. It starts with vetting the audit scenarios, continuing until the audit is completed. We're talking about doing what we call a pilot program, where when we launch a new audit, we're just doing it with a small number of people with the hope to get feedback early. Depending on the type of audit, for complex audits, it may just be more of a small number of medical records requests rather than actually truly doing it as a pilot, but more just doing it on a smaller scale and then soliciting feedback. And again, our interest is to serve our mission, and part of the mission is complying with statutory requirements, and that includes the RAC audit process. But we also want to take into consideration the interests of the stakeholders and the providers, and that's you, and be sure you feel like you understand what the rules are and have input into, well, I don't think this is a fair rule, et cetera, et cetera. So, next slide, please. So the last thing is that after all this preparation, and it has been a lot of preparation, the expectation is that our first automated audit pilot will occur this month, and probably as even as next week. The two audits that we feel like we have approved to move forward are emergency medical transport EMT trips with no corresponding medical claims, and then professional duplicates. The first complex audit we expect should roll out in December of 2025, again with a small number of records requests, very limited, so that we can really assess the program before we get too far into it, and have providers utilize resources and that sort of thing. We want to be sure that we've got a good solid audit that everyone agrees that the process is working for, and that will be related to DRGs. So with that, I will turn it over to Stephanie or Megan, and we'll go from there. Thank you very much.
Oh, you're on mute, Stephanie.
Would you like to introduce the poll for everyone?
Sure. So we have put up a poll, or actually Kelly has put up a poll that we're asking you all to provide feedback on what topics and that you're interested in, because as Dr. Jeff said, there's never going to be one specific topic that's going to cover all providers, since we have different provider types. And we seem to only hear from certain providers for certain subjects. So I open the door and the invitation for all provider types to give us feedback and topics for the stakeholder engagement. And of course, the stakeholder engagement is meant with the bill as well. When the audits start rolling out, it's more focused on the education and going through the audits of what we find, speaking with providers and providing that information. Since we haven't had any audits, and we listened to you all last stakeholder engagement, this was the hot topic that you wanted. And also we know that the hot topic is to hear about the updates as far as what the RAC audits are going, when they're going to be rolling out. So with that being said, we do have an ad hoc provider advisory board meeting on Monday, November 17th, that was just put together. And the link for that to register, of course, all of our meetings are recorded and posted after, is on our website. And Kelly is going to put that in the chat, the link to register. I welcome everyone. We're going to go over 2 scenarios, as well as the board is going to do a vote on some verbiage that we need for a reasonable time frame. So that is going to happen on Monday. Also, our website by the end of the week is going to be updated with information that you've heard today, as well as more information pertaining to how HMS has made a lot of updates and improvements to the HMS provider portal. And we strongly encourage all of you to make sure that you're registered with this portal, in this portal. Review the information in the portal and make sure that everything is current and up to date. Go through like the email addresses for who would be contacted, And I also I cannot emphasize this enough, that the HMS provider portal is an entirely separate portal than the provider interchange portal. So with that being said, though, I will ask if everybody could update the provider interchange portal as well and make sure that your information is up to date there too. Um, the DRG complex audit, like Dr. Jeff said, is tentatively going to roll out on a limited basis next month to all providers. And as he said, there's no way to really do a pilot for the DRG audit because, the complex audits are focused on specific provider claims with medical records requests. The two automated audits that he said that will go out, I think letters to the pilot group of providers will go out next week. And this pilot is going to be starting with the new RAC processes. Dr. Jeff and I will be working closely with the providers as well as with HMS to roll this out. Once the RAC pilot providers receive the audit letters, they're going to work closely with us on the new processes, any feedback that they have, and just really together before we roll this out to the entire provider community. As always, we are committed to working closely with all of you guys and streamlining the process and eliminating waste. We truly do appreciate your participation and feedback. As we all know, nobody likes to be audited, but unfortunately, this is a part of what we do and what has to be done. So why not, collaborate to make it a lot easier for everyone. And with that being said, I don't have any other updates other than I'm going to put in a plug to please. I can see all the website traffic, and I don't feel like the providers are really utilizing it, but not just providers, it's everyone. So we're really going to be changing our website as well with HMS to align. So a lot of our updates, a lot of our videos or recordings from past meetings, everything is on our website. So I'm going to direct everyone there. Please, please, please utilize it. And by the end of the week, the information that we went over today will be up there for you as well. And as always, if you guys have any questions, you know how to reach me, and I will get back to you. All right, Stephanie.
So I see we have 2 responses to our poll. Please, please do give us feedback of topics that you would like either Dr. Jeff to cover, related to clinical things or related to specific kinds of questions that you might have. Or if there are other things that Megan or I or others from the RAC team could cover for you, if you have questions about those things. We want this meeting to be useful and productive for you. And so to help us do that, it's really important for you to tell us what is useful and productive for you. So thank you for the 2 folks who put their responses in there. If you haven't already, please do add something there. We're excited to get things going again. As Dr. Jeff said, we've spent a lot of time really taking a thoughtful and deliberate approach to relaunching our audits. There are lots of opportunities for providers to engage with us before an audit is ever launched. And so we really want to hear from you and understand things that are working well, changes that we've made, if you like those changes, if things are still not working great for you, or if you have questions about things, we'd like to know that as well. So we just really do appreciate your engagement. We know that nobody loves to be audited. We don't like to be audited either. But it is something that we all need to be able to do, and we want to make it as easy and painless as possible for everyone. So thank you very, very much. And I know Megan will get to the questions here. If you have questions, please put them in that Q&A, either for Dr. Jeff related to the malnutrition information that he presented or any other questions that you might have.
We do have a question of, can we submit a response to the poll at a later time via email? Let's see. I am going to check with Kelly on that and I can answer that. Get back to
So,
that.
well, I'll let you know too, there is always the opportunity for you to give us input. And Megan, is there a way that we could pull up the form on the website that allows folks to send us inquiries? You are always welcome to do that for anything, anytime. And absolutely, if you have suggestions about things or even questions about things or just want to talk more about something, outreach us. Outreach me, outreach Megan, outreach Dr. Jeff. I know after the last stakeholder meeting where Dr. Jeff talked about sepsis, quite a few folks outreached him and he was able to connect one-on-one and really talk through a lot of things. That's exactly the kind of thing that we want to see happening more of. So appreciate that. And yes, you are always welcome to connect with us in any of those different ways. Sarah, I actually was just looking at an email from you to respond to you about exit conferences. So exit conferences are available only for complex audits. And the way it works is you can request an exit conference and or an informal reconsideration for complex audits. And the reason we've built it that way is so that you have two opportunities to connect with both us, and that is going to be Dr. Jeff from the clinical side and other folks from our RAC team, as well as HMS, to really talk through any questions, any concerns, any issues that you're seeing with the audit or specific claims and preliminary findings for those claims, that kind of thing. So you have two opportunities before you ever get an actual finding to sit down with us and talk about those things. So both for the exit conference and for the informal reconsideration, those will be preliminary findings. You will not get any kind of notice of formal findings until after an informal reconsideration has been completed. And that allows us and you, like I said, to go through the claims that are part of that case and say, yes, we agree, these should be overpayments. Or, you know what, we agree with you, provider, these probably shouldn't be overpayments and we'll overturn them. So it allows us an opportunity to course correct with any of those claims that we can talk through. And so that we know exactly at the end of that time frame what should be an actual overpayment and what shouldn't. And if you continue to disagree with our findings, then once you've been through an informal reconsideration, you have the opportunity to appeal. It is really important for providers to know that based on the new legislation that passed this last session, if you do not go through an informal reconsideration, you will not have the opportunity to appeal. So you cannot go directly to an appeal. You must go through an informal reconsideration. But with the complex audits, you also have the opportunity to do an exit conference. The exit conferences aren't available for the automated audits. And that's largely just because you will have the opportunity to do an informal reconsideration. And because our automated audits are typically less complicated, right? They're typically about a particular issue or a particular thing. So it doesn't require as much in-depth review of lots of different kinds of things. So, but you still will have the opportunity to do the informal reconsideration. It still will be based on preliminary findings, and you still must do an informal reconsideration if you want to do an appeal. So I hope that answers your question about that. We'll have a lot more of that information on the website, on our website, on the HMS website. And you're also more than welcome to reach out to any one of us again for follow-up on those questions. Cindy, your question about exit conferences were required. None of it is required. You don't have to do an exit conference. You don't have to do an informal reconsideration. The only caveat I will say is if you choose not to do an informal reconsideration, whether that's for a complex audit or an automated audit, you will not have the opportunity to appeal any of the claims in your case. So that is the key thing that changed with the new legislation. You must do an informal reconsideration if you want to do an appeal. Any other questions about malnutrition or any of the things that Dr. Jeff talked about or any of our audit updates? I was trying to give people a little bit of time to type if you were trying to type something. We are very excited to get things started again. Very excited for all the input that we have gotten from many of you. We appreciate that so much. We're looking forward to the pilot process with these first 2 automated audits that are going to be coming out in the next week or so. HMS has made a lot of updates to the website, to the provider portal. They're really designed to help us and to help you, again, keep track of all of the different claims in a particular audit and making sure that we're all in agreement about should they be findings, should they not be findings, were they upheld, were they overturned? All of that is going to be now included in the website or in the portal for us to be able to stay on the same page with the status of each claim as we go through the process. So we're very excited about that.
72 other questions came in.
Okay. So Sarah, yes. So anything that was in appeal is moving forward through that process. And as you probably know, that takes a little bit of time. I think we are down to only a handful of appeals at this point. Anything that was not appealed, but was, for example, part of the paused audits in 2024, there's a whole rescission process that's happening for that. And if you have specific claims that you've not received any kind of a rescission letter for or a closure letter for, please let us know that because we're trying to do that final cleanup with HMS right now. And some of it, I think, is a matter of timing and what we show as closed and what you may show as closed. So we know there's a few of those still outstanding. And so please do contact us. Lydia Clark is the person who is taking care of that specifically, but you can contact any of us and we'll get you connected to her to go through that and make sure that we can work through each individual claim with you and the status of that claim.
And then it looks like, I don't know, exit conferences be recorded?
That is totally up to you. I mean, if you want them to be recorded, we certainly can. As long as everyone in the meeting agrees, that's an easy thing to do.
Well, and I think just to answer the second part of that, will it be shared with the providers? Our hope is that the providers will be participating so that we can sit down and when I say face to face, at least on a video conference. And one of the things I think that we're hoping will change is that we do a really good job with exit conferences, so we have less where we need to go to informal reconsideration and appeal, and that saves your facilities resources. Hopefully, we'll have clear answers to questions that people bring up early on, so that we don't have to go through multiple levels, which I think will be good for everyone involved.
Yeah, and absolutely, Sarah, if we're going to record them, if you want them to be recorded, we would absolutely share those with you. We're not going to record them and hold on to them, but if you want it to be recorded, absolutely, you would have access to that. Any other questions? Comments? Thoughts? Again, please do tell us if there are topics that you would like for us to cover in future stakeholder meetings, what would be helpful, what you'd like more information about. By the time we have the next one, we'll have a couple of these under our belt. So I'm hoping that you will have some more great input to bring back for us.
In the Google, it looks like the poll was turned into a Google form, so it's going to remain open for a week. So if anybody wants to add to that, it closes the end of business on 11/20.
Fantastic. Thank you, Kelly. That's our behind the scenes guy taking care of us there. All
I don't
right, Megan.
see
Well, if
any.
we don't have any other questions, I think it's up, we can close out, give everybody a few minutes back.
Yeah, it looks like there's no other questions rolling in. So with that being said, like I said, you can go to our website, and I believe Kelly put the link in the chat to register for our Provider Advisory Board ad hoc meeting on Monday, November 17th. And then the next stakeholder engagement is, let's see, actually, no, yep, the stakeholder engagement. Let's see, let me believe we just scheduled, I just scheduled for next year. So yeah, so on our website as well, we have the 4 meetings for next year for 2026. So you can click on one of the dates there and actually register for all the meetings at once. So all the stakeholder engagement have been up. As far as next year's Provider Advisory Board, I'm still working with the Provider Advisory Board to get some dates collected, and then those should be posted as well for 2026 soon.
Oh, couple quick questions. Time frame from receiving the preliminary to the actual conference. I believe you have 30 days from receiving the notice of preliminary findings to request an exit conference. And there's a time frame for when that has to happen, which I cannot remember off the top of my head, but it will be that information will all sort of be on the website. But your notice of preliminary findings will be very clear about the timing and how much time you have to do either an informal reconsideration or an exit conference, depending on what type of audit it is. But I think it's about you have 30 days. It has to happen within 30 days or something like that.
I
You
believe
have to
you have to notify that you would like an exit conference within 30 days, and then it has to be scheduled within 60 days, is my
yeah,
recollection.
it's something like that. We can double check on that for you, Cindy and Roxanne, and just make sure that we get that out.
I don't see any other questions. So with that being said, I guess I'll give about 20 minutes back to everybody.
Thank you, everyone.
Thank you, everybody. Have a great day.